Dr. Stephen Frank is a professor of anesthesiology and medical director of the Center for Bloodless Medicine and Surgery, and also director of the Patient Blood Management Program at Johns Hopkins. And in terms of his clinical work, he specializes in anesthesia for vascular, thoracic, and transplant surgery. And he is well known to you for his many interesting and clinically important publications on how patient blood management and bloodless medicine and surgery can illuminate and further our ability to take care of patients with better outcomes. And so he's working on, as Dr. Trentino talked about, large data and even bigger data. And he's on editorial boards of important journals, and he's served on the board of directors for the AABB and the Society for the Advancement of Blood Management. And in his capacity as an anesthesiologist, he has been chair of the Patient Blood Management Committee for the American Society of Anesthesiologists. He's won awards for teaching and for clinical excellence. And he, in fact, won an award from this society in 2021 for his contributions. So, Dr. Frank, share your screen and share your wisdom with us.
Yeah, hi, Nate. Thank you for finding the slides. Thanks, Neil, for the handoff and the introduction. I think you can hear me and see me now, I hope. So we're going to talk about bloodless medicine and total avoidance of perioperative transfusions. And we're going to also focus on how we use informatics. Next slide. All right, so here's my disclosures. A few committees and advisory board for Haemonetics, who makes TEG and cell savers. Next slide. Here's our objectives. We're going to talk about Jehovah's Witness patients and why they believe they should avoid transfusions. We'll talk about important methods we use to optimize patient blood management and to avoid transfusions. And then also, how do we look at outcomes and costs in terms of bloodless medicine and informatics. Next slide. So who are these patients who can't be transfused? Well, in our institution, about 90% of them have personal or religious reasons why they decline transfusions, and most of them are Jehovah's Witness patients. The other 10% are those with multiple alloantibodies, where it's very difficult to cross-match, or in areas where blood is not available, such as remote or austere locations. Next slide. So where do the Jehovah's Witnesses get these ideas they need to avoid transfusion? Well, these are the three places in the Bible where their version of the scriptures say that you should not consume blood. They even say you should not eat blood, shall abstain from blood. And I always thought this was fascinating because I think this is the same place in the Bible where kosher Jewish food and halal Muslim food believe you should drain the blood out of the animal before it is slaughtered. So I really think these all come from the same place. Next slide. So we used to think the Jehovah's Witnesses were kind of crazy until 1984, because you can see on this timeline, next slide, it's going to show an arrow, that 1984 was the absolute worst year to have a transfusion, because hepatitis C in the red line and HIV in the green line were actually, it was the worst year to have a transfusion because neither one of these viruses was being tested in 1985 when the HIV test came out. And it wasn't until 1990 when the hepatitis C test came out. And you could see the blood was very unsafe even up until about the year 2000 when it got safer. Next slide. So in terms of Jehovah's Witnesses, a lot of physicians get confused when they don't know their beliefs. And I tried to simplify it in this slide, which was taken from jw.org. And I tell my friends at work that Jehovah's Witnesses do not accept red cells, plasma, or platelets. I call those the big three. And they also don't accept whole blood or white cells, which are pretty rarely used, except whole blood is making a comeback in trauma. But in the green arrows, these are considered personal choices, and each person must decide for themselves whether they accept things like albumin or cryoprecipitate, which are derived from human blood donors, and also PCC, prothrombin complex concentrate, which is rich in 2, 7, 9, and 10. And then there's also these blood substitutes called hemoglobin-based oxygen carriers, which have not made the market yet because they haven't been FDA approved. And there's one called Hemopure or HBOC 201, which is a personal choice. Next slide. So we've had a program since 2012 at Johns Hopkins for patients who don't accept transfusions. And what I like to say is bloodless medicine and surgery programs have a lot in common with patient blood management programs. Next slide. And you can see there's a lot of overlapping principles that I'm going to go through one by one. For either reducing transfusion completely in a bloodless program. And we'll go through what they share in common in the next few slides. Next slide. So we talk about optimizing red cell mass or treating pre-op anemia. I'm a cyclist myself. One of my heroes was Lance Armstrong. His drug of choice was erythropoietin. And I use this to demonstrate the importance of treating pre-op anemia because I tell our patients, hey, we might give you this drug that the Olympic athletes use, but for you, it'll be legal. It turns out, though, we give a lot more iron than we do erythropoietin because the most common cause of anemia worldwide, and even in the United States, is iron deficiency. Next slide. So oral iron is effective, but relatively poorly absorbed. Only about 10% of oral iron is absorbed. And some people claim there's side effects like cramping or bloating in the GI tract. I personally take oral iron every time I donate blood, and I don't have those side effects. But because of oral iron side effects and the poor absorption, we often go to intravenous iron. And here are the 6 different IV iron compounds that are available in the US right now. We tend to use the iron sucrose for inpatients because it's the least expensive. And we use iron dextran or Infed for outpatients, the low molecular weight iron dextran on the left, because we can give a whole gram in one visit, and the cost is only about $280, whereas some of these other compounds can be as much as 10 times more expensive. Next slide. So at our institution, we have what I call the erythropoietic order set in EPIC. The real name for it is a blood refusal medications order set, and that's how you find it in EPIC. And it gives the doses, the routes, the frequency, and the duration of treatment for everyone who is not familiar with these medications, which is 90% of the doctors and nurses on the floors. We put this into a neat order set, and sometimes we modify these doses. For example, we've gone up to 40,000 units of erythropoietin twice a day for patients with severe anemia. And note that we give our erythropoietin intravenously because we think it's more effective than subcutaneously. Next slide. So when you talk about treating pre-op anemia, we came up with a novel algorithm that tells you the optimal target hemoglobin that you need before surgery to avoid transfusion. And what we did is we took the allowable blood loss formula that we learned in anesthesiology, and we algebraically solved it for pre-op hemoglobin. And I'll show you how that works on the next slide. So this is the classic allowable blood loss formula that we learn in anesthesia as residents. ABL is allowable blood loss. EBV is estimated blood volume. And then you have pre-op and post-op hemoglobins. So we solved it algebraically for the pre-op target hemoglobin. And this is what you come up. And I can explain this better with the picture on the next slide. Okay, so when you put the numbers into the formula, this is what you get. On the x-axis is the patient's body mass in kilograms, because larger patients have a larger allowable blood loss because they have larger blood volumes. On the y-axis is the target pre-op hemoglobin you need to avoid a transfusion. So for example, in the yellow line, with an estimated blood loss of 1,000 mLs, if you're a 100-kilo patient, you need a pre-op hemoglobin of about 9. See, the 50-kilo patient losing that same 1,000 mLs of blood, you need a target pre-op hemoglobin of about 11. So this is pretty much what we use now to calculate the goal hemoglobin before surgery in patients who don't accept transfusion. Next slide. So we had a review article 3 years ago in Anesthesiology on how to manage patients for whom transfusion is not an option. Next slide. And in table 1 in this paper, we talk about pre-op, intra-op, and post-operative interventions. We're going to go through these one by one. We already talked about treating pre-op anemia, managing iron deficiency. It's also important to discontinue anticoagulants. That seems obvious, but there's so many anticoagulants nowadays that the guidelines are sometimes hard to follow. Intraoperatively, we can do simple things like maintaining normothermia to reduce bleeding, controlled hypotension, especially for orthopedic pressure closer to 70 compared to antifibrinolytics like tranexamic acid. A gram of tranexamic acid costs about $20. It's now being used, we call it a game changer in the blood management world because it reduces bleeding and transfusion by about 30%. if you look at all the studies on tranexamic acid. Meticulous surgical technique. We'll talk about that in a minute. But let's talk about postoperative. We can decrease phlebotomy by number of blood draws and the size of the phlebotomy tubes. I'll show you those tubes in a minute. We can tolerate lower hemoglobin levels because patients do fine with hemoglobins below adapted to those hemoglobins. Next slide. Okay, so of these methods in the table, about 12 of them involve what I call keeping the blood in the patient, or reducing blood loss. Now, does it go forward? Okay, yeah. So this is great. Thank you. So, like I said, 12 of these 16 methods involve keeping the blood in the patient. Minimally invasive robotic approaches, normothermia, controlled hypotension, tranexamic acid, and next slide. Here we go. So we talk about meticulous surgical technique. And so I made this graph to illustrate what that means. I like to say that blood loss is indirectly proportional to how hard the surgeons try, because when they try harder, they lose less blood. I learned this, for example, we do a lot of Whipple surgeries for pancreatic cancer. Every time I bring in a patient for a Whipple, the surgeons will lose about half as much blood if the patient was a Jehovah's Witness. So they either tie off bleeders, or they just take their time, or they don't let the intern do the anastomosis, but they definitely can reduce bleeding if they try harder. Next slide. So what about temperature and hypothermia? It turns out that even mild hypothermia during surgery, even by 1 degree centigrade of hypothermia, can increase bleeding by 16%. And this is from a meta-analysis. We used to think at 35 degrees, patients bleed more, but now we see that even at 36 degrees, patients bleed more. Next slide. So this is the meta-analysis by Dan Sessler and his group, showing that even with mild hypothermia at 36 degrees centigrade, there was a 22% increase in the risk of transfusion. So aggressive warming during surgery is something we recommend for patients who don't accept blood. Next slide. So what about cell salvage or the cell saver? A lot of people that don't work in the operating room, they don't even know what this looks like, but here is an example of a cell saver. Cell savers came out in the late 1970s, just in time for the HIV crisis in the blood supply in the 1980s. So everybody wanted cell saver blood back then. And I still haven't met a patient yet that wouldn't rather have their own blood back compared to someone else's blood from the blood bank. Next slide. So we looked at the quality of cell saver blood by looking at 2,3-DPG concentrations. And the cell saver blood in green had normal 2,3-DPG concentrations, the same as pre-op fresh patient blood shown in dark blue. But stored blood or banked blood was about 90% depleted in 2,3-DPG. And that happens after about one or bank blood is left shifted. And we had a co-oximeter in our lab. Can we do the next slide? There we go. So stored blood or banked blood is left shifted, meaning it has more difficulty offloading oxygen at the tissue levels. But fresh blood and cell saver blood were identical because cell saver blood's only been outside your body for a couple hours, as opposed to banked blood, which we store for up to 6 weeks. Next slide. So our paper was written up in the media about the higher quality of cell saver blood compared to banked blood. And they said we recycle a lot of things like paper, plastic, and metal, but we can also recycle blood and give patients back their own blood during surgery using cell savers. Next slide. So it must have been a slow week in the media because even the New York Times chose our small study to talk about the benefits of giving patients back their own blood during surgery and how we think that cell saver blood is higher quality than banked blood because of the 2,3-DPG levels, but also because the cell membranes are more deformable, and the cell saver blood doesn't have the storage lesions that develop in banked blood. Next slide. So what about phlebotomy blood loss? We talk about keeping the blood in the patient. And we took a survey in the 5 adult ICUs at Johns Hopkins. It turns out that 60 mLs a day on average were removed from the patient for phlebotomy, which is about 1% of your 5-liter blood volume, which is how much erythropoiesis you have every day. You destroy and create about 1% of your blood cells. So this is a lot of blood we're sending to the lab. And in the neurocritical care unit, they use this inline device to reduce the wasted discard. Next slide. And we have switched the entire hospital at Johns Hopkins to the pediatric size tubes shown in the middle that hold between 2 and 4 mLs. We hardly ever use the adult size tubes that hold 5 to 10 mLs. And for special patients like Jehovah's Witnesses, we'll use these tiny little neonatal tubes that hold 0.5 mLs or 1/20th of the blood that's in the large adult tube. Next slide. So what about tranexamic acid? It's being called the game changer now in the orthopedic world. We started using it in hip and knee replacements, and we saw this dramatic decrease in red cell transfusion rate. We also hired 4 new surgeons at the time, and 2 large random showing less is more for transfusion. But nonetheless, tranexamic acid has been around for 50 years, but only in the last decade are we using it now to reduce bleeding and transfusion. Next slide. So like I said, there's 2 artificial blood substitutes that tried to come on the market. Sanguinate failed, is no longer available. Hemopure is still trying to come on the market. It's a bovine hemoglobin that's been polymerized and cross-linked. It has a very high P50, so a right-shifted curve for hemoglobin oxygen saturation. And it causes nitric oxide scavenging and some vasoconstriction. And if you give too much of it, you can get methemoglobinemia. So it's still not FDA approved, but we have used it for compassionate use in some Jehovah's Witness patients. Next slide. So what about legal activity around patients who decline transfusion? This was a case in Philadelphia, a cesarean section patient who died after bleeding from postpartum hemorrhage. And it turns out that even though she signed the consent that she didn't want blood, there was a lawsuit anyway. And what these cases boil down to, for the most part, is recognizing the hemorrhage quickly and taking the patient back to surgery to stop the bleed without delay. And that's how physicians and nurses can be liable for a case like this if you don't recognize and treat the bleeding in a timely fashion. Next slide. So we looked at over 1,000 patients in our bloodless medicine program and their outcomes compared to patients who accept transfusion. Next slide. So we looked at a group of 1,000 bloodless patients, compared them to matched controls. We used ICD-10 codes to look at morbid events in the hospital. And when we looked at ischemic events like stroke and heart attack, there was no difference. Respiratory events, renal dysfunction, thrombotic events, no difference. But we did find less infection. That's hospital-acquired infection in the bloodless patients. And I believe this is a true benefit to bloodless care, because Neil Blumberg and his group in Rochester have clearly showed, even in a meta-analysis of randomized trials, that banked blood can predispose patients to hospital-acquired infection. And if you can avoid banked blood, you can reduce infection. Next slide. We also look at cost and care, and these are medians and interquartile range. We found 8 to 9% lower cost with the bloodless care. So what we're doing for these patients not only improves outcome by reducing infection, but also saves cost because blood is expensive, and so are hospital-acquired infections. Next slide. So GI bleeds are something we see quite often. And we took a series of patients who came in for GI bleeding who declined transfusion, and we mapped out their first, lowest, and last hemoglobins. And we had 10 patients with nadir hemoglobins less than 5, and only one of them died. The threshold of 5 grams per deciliter used to be of a threshold for increased mortality. But with modern care and aggressive treatment, like we've described, we only have 1 death out of 10 with nadir hemoglobins less than 5. Next slide. And I got permission from this patient to take his picture with his wife. He had a GI bleed about a year ago, came in with a nadir hemoglobin at 2.1. The medicine served on palliative care because they were convinced that he was going to die, and he was adamant about not taking transfusions. So they put him in the ICU, and we gave him aggressive treatment with tranexamic acid, a high dose erythropoietin, even added darbepoetin as a second erythropoietic medication, iron, folate, B12, and we totally minimized phlebotomy. And guess what? He went home on day 17 with a hemoglobin of 5.7, and he really surprised all of us. Next slide. This is his hemoglobin trend. You can see there were multiple days where we didn't even draw blood to measure his hemoglobin, but we did treat him aggressively with those erythropoietic medications. Next slide. So what about pediatric patients who belong to families of Jehovah's Witnesses? This has been a really hard ethical dilemma because at least in the United States, parents are not allowed to refuse life-saving therapy for their children. Next slide. So we took about 200 children of Jehovah's Witness families in our bloodless medicine program. And we found that in these 200 children, we had no mortalities. We had no court orders because we avoided that. And only 6% of the pediatric patients received any allogeneic transfusion. What we tell the families is we'll do everything we can to avoid blood. And we tell them those methods like tranexamic acid, cell savers, erythropoietin, keeping your child warm during surgery. We tell them all these things we're going to do to reduce or avoid transfusion. And then we tell them if their child's life is threatened, we're legally obligated to give them blood. And it turns out 6% of those patients got some allogeneic blood. Next slide. And in fact, in these pediatric patients, they did as well or better, shown in blue, compared to standard care patients in red, because mortality was 0 and composite morbidity on the left was significantly lower in the bloodless group. Next slide. We're almost done. Sorry to run over. But we looked at 10 years of our comprehensive patient blood management program. And we looked at the cost-benefit ratio, and we found that we had a 7.5-fold return on investment for our PBM program with equivalent or improved outcomes. Next slide. So on the left, we show 10 years of blood utilization with a $3 million decrease in annual blood spend. We went from $27 million to $24 million a year. So that's about a $3 million cost savings. And then on the right side are the revenue brought in by Jehovah's Witness patients. In the yellow line is the net margin, and we're bringing in about $5 million a year in margin to Johns Hopkins Hospital by taking care of our Jehovah's Witness patients. So that's an $8 million a year benefit for the hospital, which is a 7.5-fold return on investment. Next slide. So I never thought this would happen when we started our bloodless program in 2012. But we've had now 13 publications on the last slide in the last 10 years. So 13 publications on bloodless medicine, everywhere from review articles to a case series with outcomes. And I never thought this area would be so fruitful, but we're learning lessons from patients who decline transfusions that allow us to reduce blood utilization in all of our other patients. Next slide. And this is my last slide. Pressure patients, prayer, proline, plasma, and platelets. This is our most famous surgeon who's done over 3,000 Whipple surgeries at Johns Hopkins. Of course, when patients decline transfusion, we might not use plasma and platelets, but nonetheless, I like this algorithm. Next slide, I think that's it.